And now remodeling in cardiomyopathy. When remodeling happens, so remodeling of the ventricles. So when this happens, typically this is a compensatory reaction. The heart somehow fails and it's compensating, or it's compensating to some external trigger. So when we're talking about remodeling, we are looking at a heart that it's sort of normal, or at least the cells that are changing that are normal in a way, and that the impulse is just coping with something. In contrast, cardiomyopathy, that means that there's a problem within the cells of the heart. So typically over here you can talk about genetic diseases, genetic problems, or mutations, but very much think of some predisposed inherited factors, okay? Yeah. In contrast to remodeling. So basically over here, the cardiomyopathy, you can call it primary cardiomyopathy. And some people call the remodeling secondary cardiomyopathy, but rather don't use it, rather use the term remodeling. But both is okay if you think about it. So remodeling, typically you see if something happens to the heart and it's trying to fight the problem. So for example, it's after MI. So if I'm having MI, that's a ischemic remodeling, okay? So ischemic. So I'm having a MI. So part of the wall dies. So what means over there's no contraction. And now it depends how big muscle dies, but the rest of the muscle has to compensate that, okay? And because it's dead, there is a scar, and typically the heart enlarges, okay? It's a, let's say, eccentric hypertrophy, okay, or dilation, okay? And some parts are getting hypertrophic a bit, and some dilate, okay? The muscle that survives tries to compensate the loss, and it gets thicker a bit, but it's not like concentric, it's eccentric, and there's a dilation of the heart, okay? So that's remodeling. So there is an external factor in a way. Even better to understand the external factor is the hypertension or valves, valvular problem, like stenosis and regurgitation of the aortic valve or mitral valve, okay? So in hypertension, how it is in hypertension, I'm having for many years hypertension. So what my heart will do, it will hypertrophy because it's working against a tougher load, and it will get thicker like that, okay? So again, this would be what dysfunction, diastolic dysfunction. Or the valves will have stenosis. So if I'm having a stenosis of aortic valve, of course, the heart will also hypertrophy, okay? But it's rather called remodeling, or you can call it a secondary cardiomyopathy. Primary cardiomyopathy, it's different because very likely it's due to genetics in many cases. So it's idiopathic or genetic or whatever. And what do you account for that? And it's less common, of course. The most common is the ischemic one or hypertension. Yeah, these are the most common. But the cardiomyopathy itself means I'm having an inherited problem. And without any hypertension, without any ischemia, whatever, suddenly the heart gets dilated. Okay? So I'm having a dilated cardiomyopathy. That's one scenario. Or, again, inherited problems, my muscle itself hypertrophies. So it could be hypertrophic cardiomyopathy. It could be the restrictive one, restrictive cardiomyopathy. So in this case, typically, this is related to sarcoidosis, amyloidosis, hemochromatosis, that could also, although the hemochromatosis can do other cardiomyopathies as well, but remember this one, typically if amyloid gets stuck in the heart, it won't get as elastic, it's going to be restrictive, yeah? Or you can have one special one, it's called Takotsubo. And this is the broken heart by love, okay? So if a girl dumps someone, then It can be so severe, such a big stress, that the catecholamines, and it's due to a burst of catecholamines, can cause a special type of cardiomyopathy, which is located, it is located in the apex of the heart. But there are even worse situations, like if a child dies. So this is the one. And some people die on it, okay? So guys, don't take the girls so seriously. You know, they don't know what they want at the end. And, you know, you will always find a better one.
No, it's not true.
It is. But anyways, good message for you is it's reversible in most of the cases, okay? So if the catecholamines decrease, the stress disappears. This one itself improves, okay? So Takotsubo cardiomyopathy, described in Japan, okay? And these are the main ones, so you should remember, but as I said, it's specifically connected with the cardiomyocytes, okay? But anyways, all of these can cause some kind of congestive heart failure. And of course, cardiomyopathies are rare, much rarer than MI and then dilational congestive heart failure. So what I want to point out over here is when I talked about the hypertension. Because if there is an MI, that's obvious. I'm going to rather have a dilation because I'm losing part of the wall. Over there, the wall gets thinner and the heart will dilate. But with hypertension, we could say 30% or even more of the, let's say, hypertrophic, it's a concentric hypertrophy, okay? So there's no dilation, it's very symmetric. But after many years with this type of hypertension, which is with diastolic dysfunction, what can happen? Suddenly I can have a dilation, so it can dilate as well, okay? In some cases, not all, but in some cases. So the hypertrophic congestive heart failure can turn into systolic dysfunction. So diastolic can turn into systolic dysfunction. Not always, but there are some shifts. Also, don't forget, once you're having hypertrophy or hypertrophic heart, it's thicker. So of course, for the coronary arteries, it's harder to supply it because it's thicker. So there is an increased risk of what? Of MI again. I'm having a hypertrophic heart, then I can have an MI and it can dilate as well. But I don't have to have MI there for dilation, not always, okay? But it's a pretty common scenario as well. So, and we're getting to the table, to the comparison. So, thanks for watching. And don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.